Hi friends, once again welcome you all back to our channel, the Nurse channel, and we are very happy to see the responses in our previous videos by you guys. Many of you have asked about certain doubts like some explanation regarding the renin-angiotensin-aldosterone mechanism, and one of our subscribers have asked about the syllabus to make questions according to the syllabus of ESIC. So these responses definitely we will take into consideration, and for your kind information we are arranging the questions in such a way that the syllabus of ESIC is also covered in our questions, and the questions for the NORCET will be little more different, like some sort of difficulty will be there for the AIIMS NORCET examination questions. So we will be considering all these things and we are framing these questions for you. So once again, thank you for the support you are rendering for our videos. And as you all know, so this is another set of 15 important questions for the upcoming AIIMS NORCET, ESIC and other competitive examination. And this is the series what we have already started for cracking these competitive exams. So once again, welcome you all back to this series, and I request everyone who are watching this video to watch the video till the end without skipping, so because the explanatory sessions for each questions are very important. Okay, so straight away without losing time we will move to the videos, to the questions. Before that, if you have not yet subscribed our channel, kindly subscribe and support us, and kindly enable the bell button so that you will be notified whenever we are uploading new videos. So straight away we'll move on to the another session, another series of 15 very important questions. So straight away to the questions. So let us begin this session with a very interesting question. So the first question in the series for you on the screen right now. So the question is, Epstein anomaly is associated with the teratogenic effect of which drug? So the question is regarding a teratogenic of a drug, and that can cause the Epstein anomaly in the kid. So the options are option number A, lithium, option number B, tetracycline, option number C, valproic acid, and option number D, streptomycin. So the options what I have given in this question have one or the other form of teratogenic effects to the baby. So here the question is regarding the Epstein anomaly. So what is the answer? So the answer for this question is option number A, that is lithium. So we know that the main effects which are attributable to lithium are, the first one is the cardiac malformation and the second one is the increased birth weight. So there is a possibility that in particular the lithium may be associated with the development of Epstein anomaly. Okay, so the main effects that can happen with the lithium intake during the pregnancy are two things. First is the cardiac malformations, and the second one is the increased birth weight of the baby. Okay, so Epstein anomaly, it is a rare congenital heart defect that affects the tricuspid valve, which causes the atrium to enlarge, which can lead to congestive heart failure. Okay, so Epstein anomaly that will result in the congestive heart failure, and Epstein anomaly is affecting the tricuspid valve. And the other teratogenic effects of the other options what I have given, we will discuss now. The first one was the tetracyclines. So we know that tetracyclines are contraindicated in pregnancy because of its risk of hepatotoxicity. Okay, hepatotoxicity in the mother, and the potential for permanent discoloration of teeth in the fetus. That means yellow or brown teeth appearance will be there, and in addition to that there will be impairment of fetal long bone growth. Okay, so tetracyclines are associated with teeth discoloration. That means yellow or brown discoloration of the teeth can happen, and at the same time there will be impairment in the fetal long bone growth. Okay, so an example for tetracycline is doxycycline. So tetracyclines are contraindicated in pregnancy. Then one more option, that is the VP, otherwise known as the valproic acid or sodium valproate, an anti-epileptic drug. So this has been associated with a variety of major and minor malformations, including a 20-fold increase in the neural tube defects. Okay, there will be chances for NTD, that is neural tube defects, then cleft lip and palate, then cardiovascular abnormalities, genitourinary defects, developmental delay, endocrinological disorders, limb defects, and autism. So it's a highly teratogenic drug, that is valproic acid, that can result in neural tube defects, cleft lip and palate, cardiovascular, genitourinary, then endocrinology abnormalities, then developmental delay, limb defects, and autism. Okay, so very important. And the final option was the streptomycin, that you all know that streptomycin can have problems with hearing and or the balance. Okay, so that's all regarding the first question. So from the first question, some teratogenic effects of the drugs are explained. So moving on to the second question in our series. So the question is, identify the blood product which is used to maintain hemostasis in patient with liver failure and GI hemorrhage. So here the patient presented with liver failure, along with that GI hemorrhage also is there. So which blood product you will administer for this patient to maintain the hemostasis? So that is the question. So the options are option number A, whole blood and albumin. Option number B, platelets and packed red blood cells. Option number C, fresh frozen plasma and whole blood. And option number D, cryoprecipitate and fresh frozen plasma. So think about the liver failure, and in the question itself they have mentioned like there is a GI hemorrhage, liver failure is there. So we have to maintain the hemostasis. So the answer is definitely option number D. We should administer cryoprecipitate and fresh frozen plasma. Why? So that we will be seeing now. So we know that the liver, it is a vital organ in the synthesis of clotting factors. So when it is diseased or dysfunctional, then obviously we will get bleeding. So the treatment should consist of administering the blood products that aids in clotting. So these include fresh frozen plasma, which contains the fibrinogen, and administration of cryoprecipitate, which have most of the clotting factors. So the primary aim in this scenario is controlling the GI hemorrhage and maintaining the hemostasis. So there comes the importance of fresh frozen plasma and cryoprecipitates. So although other options I'll explain. So we have given some other options like whole blood, albumin, etc. So the administering of the whole blood, albumin and packed cells will contribute to hemostasis, but these products are not specifically to treat the hemostasis, okay, and the hemorrhage what is occurring in the liver failure, okay. So the answer is fibrinogen containing fresh frozen plasma and cryoprecipitate. So moving on to the third question in our series from oncology. Which among the following is a major manifestation of multiple myeloma? So question is very careful, major manifestation of multiple myeloma. So the options are option number A, fever, option number B, skeletal pain, option number C, paraplegia, and option number D, enlarged lymph nodes. Major manifestation of multiple myeloma. So obviously answer is option number B, that is a skeletal pain. Okay, so we know that multiple myeloma, otherwise known as the plasma cell myeloma or simply myeloma. So it is a cancer that develops in the plasma cells. Okay, so you know that it is a type of white blood cell that produces the antibodies. So one more information, it is the most common type of plasma cell tumor and can spread throughout the body. Okay, so the most common type of plasma cell tumor is the multiple myeloma. So what is happening in multiple myeloma is, early in the multiple myeloma there might be no symptoms, or the symptoms may be vague or similar to those of the other conditions. So when symptoms are coming, when they are present, it can include bone pain. The main thing is the bone pain, especially the bone pain can be seen in the spine, chest or the hips. Then there will be pathological fractures. Then other set of symptoms are like nausea, constipation, loss of appetite, weight loss, thirst. Then comes the mental fogginess, confusion, tiredness, etc. Then infections and impaired immune function, and finally anemia. Okay, so these clinical manifestations I have clubbed it together for remembering easily. So like first one is the bone pain related things like spine, in the bone pain which can be seen in the spine, chest, hip and pathological fractures. Then GI symptoms like nausea, constipation, loss of appetite, weight loss and thirst. Then mental symptoms like mental fogginess, confusion, tiredness. Then immune system impairment and infections and anemia. So these are the features that can be seen in the multiple myeloma. So our question answer is bone pain. Okay. So moving on to the fourth question in our series from the immunology. The question is, allergic reactions caused by environmental allergens is known as. So here the question is regarding the allergic reaction which can be caused by the environmental allergens. So I think you might have gone through that immune responses like type 1, 2, 3 and 4 that will be explaining in the explanatory section. So before that we will see the options for the answer for this question. So the options are option number A, anaphylactic reactions, option number B, atopic reactions, option number C, cytotoxic reactions, and option number D, immune complex reactions. So here the question is asked about the environmental allergens, allergic reaction caused by environmental allergens. So what is the answer? So obviously answer is option number B, that is atopic reactions. So we'll have a little bit detailed explanation regarding this question. So we know that the atopic reactions, it is a genetic predisposition to develop an allergic reaction to environmental substances. Okay, this is very important, related to the environmental substances that are otherwise harmless. So it's usually a family trait that occurs in childhood or adolescence. That means there will be a family history of atopic reactions, and that will be inherited to the generations. So atopy can lead to an overproduction of which immunoglobulin, that is the immunoglobulin E, IgE, and there will be an increase in the CD4 plus Th2 differentiation, which can cause an increased propensity to hypersensitivity reactions. Okay, and the most common manifestations of atopy are, there will be allergic bronchial asthma, then allergic rhinitis, then the most common atopic dermatitis or eczema, and food allergy. So these things are coming under the atopy, and these are related to the reaction to the environmental substances. And the important thing is that you just please don't forget about immunoglobulin, that is immunoglobulin E and CD4 plus differentiation. Okay, so that's all regarding the atopic reaction. Then other options we will see. What is an anaphylactic reaction? So anaphylactic reactions occurs when allergens are released systematically. So that is important. Allergens are released systematically. There will be systemic manifestations will be there. I'm not going to explain in detail about this, so you can refer it later. Okay, then what is a cytotoxic reaction? So cytotoxic reactions occurs with blood or blood product transfusion. Okay, so this is also important, blood or blood product transfusion, cytotoxic reactions. Details you can refer later. Then comes the immune complex reactions. So immune complex reactions occurs with extracellular fungus, virus or bacteria. Okay, extracellular fungus, virus or bacteria because of the foreign living organisms. Then we will explain regarding the types, what I have mentioned in the beginning of these questions. So what are the 4 types of immune responses? So we have the type 1 reaction, which is mediated by the IgE antibodies. Then type 2 reactions, which are mediated by the cytotoxic reactions, which are mediated by the IgG or IgM antibodies. Then type 3 mediated by the immune complexes. And finally the type 4, which includes the delayed reactions mediated by the cellular response. So this slide itself is very important. So you are getting answer for many questions from this slide. Type 1 by the Ig antibodies, type 2 cytotoxic, that is IgG or IgM, type 3 by the immune complexes, and type 4 by the delayed reactions mediated by cellular response. Okay, so very important and very informative question for you. So moving on to the 5th question in our series. So what is the lifespan of platelets in idiopathic thrombocytopenic purpura? So direct question, lifespan of platelet in idiopathic thrombocytopenic purpura. So definitely for answering this question, you should know what is idiopathic thrombocytopenic purpura. So we'll see the options. So option number A, 8 to 10 days. Option number B, 8 to 10 weeks. Option number C, 12 to 20 days. And option number D, 1 to 3 days. So what is the lifespan of platelet in ITP? So what is the normal lifespan of platelet? So that I'll be discussing in the explanatory session. Before that, the answer we will see, answer is option number D, that is 1 to 3 days, and sometimes even lesser than that. Okay, so first we will see what is the idiopathic immune mediated thrombocytopenic purpura, okay, or otherwise known as the idiopathic thrombocytopenic purpura or immune thrombocytopenia. Okay, so this is a type of thrombocytopenic purpura which is characterized by a low platelet count in the absence of other causes. So there will be several other causes that can result in the low platelet count, but in the absence of these other causes, there will be a reduction in the number of platelet counts, which is accompanied by a red purple rash called purpura. So from the name itself, it is clear there will be thrombocytopenia will be there. Along with that, there will be a red purple rash called purpura also is there. So this is in brief about ITP. So we know that the normal platelet count is in the range of 1,50,000 to 4,50,000. So with ITP, the platelet count will be less than 1 lakh. Okay, platelet count will be always less than 1 lakh. This is one important information. And along with that, we'll come to the answer for our question. So ITP platelets usually survive only a few hours in comparison to the normal platelets. Okay, so in the question I have given an option like 1 to 3 days. So sometimes only for a few hours only will be platelet will be surviving in ITP patients in compared to the normal platelet lifespan of 7 to 10 days, or sometimes we will tell like 8 to 10 days. Okay, so the normal lifespan will be 7 or 8 to 10 days, and in ITP it can reduce to even hours. Okay, so that is the answer for the question. So we'll move on to another important question, the sixth question. What is the definite treatment for sickle cell anemia? So definitive treatment for sickle cell anemia. So the options are option number A, plasmapheresis, option number B, splenectomy, option number C, BMT or bone marrow transplantation, and option number D, hydroxyurea. So the options what I have given is one or the other treatment options for sickle cell anemia. So you should read the question very carefully. What is the definite treatment for sickle cell anemia? So the answer is obviously option number C, that is the bone marrow transplantation or BMT. So first of all, we will see what is a sickle cell anemia. So the sickle cell disease, so it is a genetic disorder which is caused by mutations in the beta globin genes that leads to faulty hemoglobin protein called the hemoglobin S. Okay, so it is a defect in the mutations in the beta globin genes. So hemoglobin S, what will happen is hemoglobin S changes the flexible red blood cells into rigid. So the normal red blood cells will be flexible, but in the hemoglobin S, what happens is like it will become, the RBCs will become very rigid and will be sickle shaped. And these sickle cells can block the blood flow, and that can result in the pain and organ damage and other manifestations of the disease. Okay, so as the name indicates, the RBCs will become sickle shaped and it will become rigid, and it can block the normal blood flow and can result in the manifestations. So this is in brief about sickle cell disease. So a bone marrow transplant, also known as a stem cell transplant, is the only known cure for the sickle cell disease. Okay, so the procedure replaces the abnormal stem cells in the bone marrow with healthy cells from a donor. So the transplant is usually only considered for children under 16 years of age who have severe complications from the disease. Okay, so this is another important point, the severe complications like strokes, acute chest crisis, and a recurring brain crisis. Okay, so the indication, the indication for a bone marrow transplant in children is the children should be under 16 years of age with severe complications of the sickle cell anemia, like the child will be having strokes or acute chest crisis or recurring pain crisis, etc. So this is the indication. Okay, so the other options we will see. So in case of the patients with sickle cell disease, there are several reasons indicating the splenectomy. Okay, so the splenectomy also is a treatment option, but it's not the definitive treatment. Then the indications for the splenectomy in sickle cell disease is like there will be acute splenic sequestration crisis, that is blood trapped in the spleen, and it can be usually seen in the children. Then the another indication for splenectomy is the hypersplenism. That means a case of overactive spleen removing the blood cells too early and too quickly. Okay, so if these two conditions present, then the child can be underwent splenectomy. The first one is the acute splenic sequestration, and the second indication is the hypersplenism. Then another option was the plasma exchange or the plasmapheresis. So it is a useful adjunct therapy to red cell exchange in patients with sickle cell disease and multi-organ dysfunction. Okay, so it is an adjunct therapy, not a definitive treatment. Plasma exchange. Okay, then drug I have mentioned in the option, that is a hydroxyurea. So hydroxyurea usually used to prescribe for the patients with some malignancies or the neoplasms of the blood. And this hydroxyurea, what is the function is like, it makes the red blood cells bigger. Okay, so we know that in sickle cell disease the red blood cells are getting rigid. So here the red blood cells become bigger, and it helps them stay rounder and more flexible. Okay, so in sickle cell disease, so what is the function of this hydroxyurea is that it will make the red blood cells rounder and become more flexible and make them less likely to turn into a sickle shape. So the medicine does this by increasing a special kind of hemoglobin called the hemoglobin F, that is a fetal hemoglobin. It's also called as the fetal hemoglobin because newborn babies have it. Okay, so this is the function of hydroxyurea in sickle cell disease. Okay, so that's all regarding the that particular question. So the question was definitive treatment, that was the important point. So now we'll see the seventh question from the OBG. So the question is, pelvic inflammatory disease or PID involves infection of which among the following? Okay, so the options are option number A, salpingitis, option number B, oophouritis, option number C, peritonitis, and option number D, all the above. So you should understand what is pelvic inflammatory disease, and you should understand all these options also, like what is salpingitis, oophouritis, peritonitis. So obviously the answer for this question is option number D, that is salpingitis, oophouritis, and peritonitis. So we'll have a small explanation regarding pelvic inflammatory disease. So it is an infectious condition of the pelvic cavity that may involve infection of the fallopian tube, that is salpingitis, then infection of the ovaries, that is oophouritis, and pelvic peritoneum, that is peritonitis. So it is often the result of untreated cervicitis. So this is also important. It can happen. One of the etiology is the untreated cervicitis. So the organism affecting the cervix ascends higher into the uterus, fallopian tubes, ovaries, and peritoneal cavities, and can result in the disease, pelvic inflammatory disease. So very often they can ask question like which organisms are most common organisms that can cause the pelvic inflammatory disease. So the answer is the most common bacteria that can cause PID are Neisseria gonorrhoeae and Chlamydia trachomatis. Okay, very important point. And these bacteria are STDs, that is sexually transmitted pathogens, that usually cause the PID in 85% of cases. Okay, so these are sexually transmitted organisms. The first one is the Neisseria gonorrhoeae and the Chlamydia trachomatis. Okay, so answer for another important question you are getting out of this question. So we will move on to the next question in our series, that is the 8th question. So the question is, which among the following is associated with hypoparathyroidism? So for every competitive exams, you can expect a minimum number of a percentage of questions from the endocrinology. So here the question is regarding the hypoparathyroidism. So the options are option number A, tetany, option number B, polydipsia, option number C, hypotension, and option number D, polyuria. So which one is associated with hypoparathyroidism? So the answer is obviously option number A, that is tetany. Okay, so we'll have a small discussion regarding this question. So hypoparathyroidism, so it is the decreased function of the parathyroid gland with underproduction of parathormone. Okay, parathyroid hormone. So this can lead to low levels of calcium in the blood, and which can result in the cramping and twitching of the muscles, or tetany, that means involuntary muscle contractions can happen, and several other symptoms. Okay, so hypoparathyroidism, which is because of the underproduction of parathormone, and there will be lower levels of circulating calcium, which can result in the manifestations like cramping, twitching, and or tetany. Okay, and other severe other complications. So other options we will see, I have mentioned polyuria. So polyuria is associated with the hyperparathyroidism, not with the hypoparathyroidism. And people with hypoparathyroidism have significantly higher blood pressure and stiffness of the blood arteries. Okay, so in the options I have given polyuria, then regarding the BP. So in hypoparathyroidism there will be hypertension will be there, and because of the stiffness of the blood arteries. Okay, so we'll see the 9th question in our series, another very important question. Which among the following is a feature of pneumococcal pneumonia? So the question is regarding pneumococcal pneumonia and its specific feature. So the option number A, low grade fever with mucopurulent cough and night sweat. Option number B, fever, chills and productive rust colored sputum. Option number C, fever, myalgia and non-productive cough. And option number D, fever, myalgia with foul smelling sputum. So all the options what I have given is one or the other symptom of specific types of pneumonia. So here the question I have asked is regarding pneumococcal pneumonia. So from the options it is very easy to identify. So the answer is option number B, that is fever, chills and productive rust colored sputum. Okay, so we will see each options and what each option what are the features in the each options that we will see. So the first one is a pneumococcal pneumonia. It is a bacterial lung disease caused by the bacteria Streptococcus pneumoniae. So it is the most common type of bacterial pneumonia in the adult. Okay, so answer for another important question. Most common type of pneumonia is the bacterial pneumonia, is the pneumococcal pneumonia, and it is the most common type of community acquired pneumonia. Okay, so two very important point. most common type of bacterial pneumonia and the most common type of community acquired pneumonia is the pneumococcal pneumonia. So the features we can see in pneumococcal pneumonia are, so I have already explained the this one in the options itself. There will be fever will be there with chills, then productive cough with rust colored sputum. Okay, this is very important, rust colored sputum, then chest pain. These are the common manifestations of pneumococcal pneumonia. And the other options we will see, low grade fever. The first option was the low grade fever with mucopurulent cough and night sweat. This is very important, night sweats. This indicate definitely pulmonary tuberculosis. Then another option, fever, myalgia and non-productive cough are the common symptoms of influenza, and in lung abscess patient experience fever, cough with foul smelling sputum. Okay, so all the four options I have explained. So here fever, myalgia and non-productive cough, it's influenza. Then then fever, cough with foul smelling sputum can be seen in the lung abscess. Okay, so such a very important question with the characteristics of some lung diseases. Okay, so with that we will move on to the 10th question in our series. So the question from pharmacology, the group of drugs which are used to improve the cardiac function of a failing heart by increasing its pump performance. So this is a key point in this question. So drug which can be used to increase the pump performance of the heart. So options are option number A, beta adrenergic antagonists, option number B, ACE inhibitors, option number C, ionotropes, and option number D, diuretics. So which drugs can have an increased pumping performance of the heart? So obviously the answer is option number C, that is ionotropes. So ionotropes. So you know that ionotropic agents or the ionotropes, example the dopamine, dobutamine, amrinone, it facilitates the myocardial contractility and enhances the stroke volume. Okay, facilitates the myocardial contractility and it enhances the stroke volume. So there are two kinds of ionotropes, that is a positive ionotropes and negative ionotropes. So as the name indicates, positive ionotropes strengthen the force of the heartbeat, and on the other hand, negative ionotropes weaken the force of the heartbeat. Okay, negative ionotropes weaken the force of the heart. Okay, so the other options we will see regarding the beta blockers or the beta adrenergic antagonists, it decreases the heart rate and blood pressure and thus reducing the workload of the heart. Okay, there will be reduction in the heart rate, a reduction in the blood pressure and reduction of the workload of the heart. Okay, so that is beta blockers like propranolol, atenolol, metoprolol, etc. Then comes the diuretics. So diuretics decreases the overall circulating volume and thereby reducing the blood pressure and thereby reducing the workload of the heart. Okay, so diuretics, circulating volume will be reduced. Okay, so that also was an informative question from the pharmacology or the cardiovascular disease. So moving on to the next question. So the 11th question. So which is the drug of choice for thrombolysis in ischemic stroke? So here the question is regarding the drug of choice in ischemic stroke for thrombolysis. So the options are option number A, streptokinase, option number B, heparin, option number C, RTPA, and option number D, any of the above options. So be careful with this question. The question is regarding the drug of choice for thrombolysis in ischemic stroke. So what is the answer? So the answer for this question is option number C, that is the recombinant TPA. So we will have a small explanation regarding this question. Very important question. So recombinant tissue plasminogen activator or RTPA. It is the standard treatment for acute ischemic stroke and it is the only approved therapy for strokes within 3 hours of symptom onset. So this is the golden time for initiation of the treatment, that is the 3 hours of symptom onset, within 3 hours. Recombinant tissue plasminogen activator. So the tissue type plasminogen activator, so it is a protein that facilitates the breakdown of blood clots. So it acts as an enzyme to convert the plasminogen into its active form plasmin, and this is a major enzyme which is responsible for the clot breakdown. So here we have mentioned that it is a ischemic, already ischemia has happened, so some sort of thrombolysis should happen, and this thrombolysis, that is a procedure, what that is the point that we have explained here. So it will convert the plasminogen into its active form, that is a plasmin, and plasmin is the one which is responsible for the breakdown of the clot. So that function is accomplished by administering the tissue plasminogen activator within 3 hours of the onset of the symptoms. That is very, very important. Then we will see the other options, among the patients with the acute ischemic stroke, the treatment with streptokinase was associated with no difference in the primary endpoint, but was associated with an increased mortality because of the risk of hemorrhage. So why streptokinase is not indicated as a thrombolytic agent in ischemic stroke is because of its high risk for hemorrhage, and there will not be any any improvement in the manifestations. Okay, so streptokinase is not advisable. Then heparin it is given after 24 hours of the thrombolysis, and the purpose of giving heparin is to prevent further clot formation. Okay, so further clot formation can be prevented by heparin, and heparin is not a thrombolytic agent in the ischemic stroke. Okay, so that was the other options what I have given in this question. So we will see the 12th question in our series. Another interesting question: what is the most common cause of urinary retention in female? So what is the most common cause? So the key points are most common and female. Options are option number A, cystocele, option number B, SCI, that is the spinal cord injuries, then option number C, detrusor failure, and option number D, urethral stricture. So among these, which is the most common cause of urinary retention in female? So what is the answer? So the answer is option number C, that is the detrusor failure. Okay, detrusor failure is the answer for this question. So we know that the two of the most common causes of chronic urinary retention in women are bladder muscle dysfunction, that is a detrusor muscle dysfunction, and obstruction. Okay, so these are the most common causes. So detrusor areflexia, this is a term that you can remember. Detrusor areflexia is the inability of the bladder to contract, which is typically neurological in origin. And some causes of the detrusor areflexia include spinal cord injury, fracture, herniated disc, and infection. Okay, so detrusor areflexia can be caused by some of the reasons like spinal cord injury. So spinal cord injury is not a reason for the bladder dysfunction, but this is the reason for the detrusor areflexia. Then fractures, herniated disc, and infections are the other causes. Okay, so the question was regarding the problem in the female. So what could be the problem in male? That we will see. The most common cause of acute urinary retention in men, it is benign prostatic hyperplasia, or the BPH, which is when the prostate gland becomes enlarged and the bladder wall thickens, and there will be obstruction in the flow of the urine, causing the retention of urine. Okay, so that is a BPH. This is another answer for another question that can be asked for competitive examinations. Okay, so we'll move on to the 13th question in our series regarding hemodialysis. Which of the following drugs should be withheld before hemodialysis? So the question is, which of the following drugs should be withheld before hemodialysis? So the options are option number A, insulin, option number B, calcium preparations, option number C, digoxin, and option number D, antihypertensives. So which all medicines need to be withheld? So answer is option number C, that is digoxin. Okay, why? So that will see, digoxin should be withheld before the dialysis. Although the dialysis does not affect the digoxin level, it causes hypokalemia. Okay, so hypokalemia can potentiate arrhythmias secondary to the digoxin toxicity. Okay, so this is important. So dialysis does not affect the digoxin level, but there are chances like a patient can go to hypokalemia. So hypokalemia can that predispose or potentiate the arrhythmias which are secondary to the digoxin toxicity. So insulin can be administered because they are not removed by the dialysis. The other option I am just explaining, insulin that can be administered if the patient is diabetic, insulin can be administered before dialysis also because it will not be removed by the process of dialysis. Then other calcium preparations, you know that calcium preparations are often added in the dialysate to prevent the renal osteodystrophy. Okay, so what is renal osteodystrophy? I will be explaining. Then the other option was regarding the antihypertensives. So the dosage of antihypertensives may be modified as the dialysis may cause hypotension due to the removal of the fluid. But the question was regarding which medicine to be withheld. But antihypertensives should not be withheld. We should titrate the doses according to the patient's value, because there are chances like patient can go to hypotension because of the removal of the fluid which is happening during the process of dialysis. Okay, so the calcium preparation, that is a renal osteodystrophy. What is renal osteodystrophy? That is also a question that can be asked. So it is a bone disease that can be managed with medications given intravenously during the hemodialysis treatment. So these medications can include phosphorus binders. Okay, so renal osteodystrophy can be prevented by medicines like phosphorus binders, then activated vitamin D, and medicines that block the parathyroid glands. Okay, so the medicines include phosphorus binders, activated vitamin D, and the medicines that can block the parathyroid gland. Then the other treatment options include dietary changes, nutritional supplements, and exercise. Okay, so this is in short regarding the renal osteodystrophy. Okay, so very informative question for you. Now we will see the second last question in our series. So another important question: which among the following drugs can have interaction with the hypoglycemic agents? So hypoglycemic agents, that is anti-diabetic drugs. So which among the following drugs can have interaction with and hypoglycemic agents? Okay, so option number A, diclofenac, option number B, aspirin, option number C, clopidogrel, and option number D, pantoprazole. So among this one medicine can have interaction with some with the hypoglycemic agents. So which is that drug? So that is aspirin. Option number B, aspirin is the answer. I think regarding this question we have already discussed in our old videos. So aspirin, it stimulates the insulin. Okay, aspirin itself can stimulate the insulin and glucagon secretion and increases the glucose tolerance in normal and diabetic subjects. Okay, so aspirin can have influence on these things, that it can stimulate the insulin and glucagon secretion and thereby increasing the glucose tolerance in normal and even in the diabetic subjects. Okay, so aspirin is the answer for that question. So with that we will move on to the last question, and that is from the simple anatomy question from the lungs. So the question is: the oblique fissure of the right lung separates which of the two lobes? Okay, so the question seems easy, but the options can be slightly confusing. So the options are: option number A, middle lobe from the inferior lobe, then option number B, inferior lobe to the superior lobe, then option number C, superior to the inferior lobe, and finally inferior lobe to the part of the superior lobe. So what is the answer? So just think about the number of lobes in the right lung and in the left lung, and number of fissures in each lung. Then you can come to the answer of this question very easily. So here the question is regarding the right lung. Remember, right lung and the oblique fissure. So the answer is option number A, that is middle lobe from inferior lobe. Okay, so for better understanding with the help of this picture I can explain. So here is the picture of the lung, and you can see the right lung and the left lung. So you know that the right lung, it has three lobes, that is the superior lobe, middle lobe, and the inferior lobe. And on the other hand, the left lung have only two lobes, that is the superior lobe and the inferior lobe. And we can see some fissures. Okay, and this each lung, you know that it is conical in shape, and it is divided into lobes by the double folds of the visceral pleura, which is called as the fissures. Okay, so what is this fissure? Fissure is the double fold of the visceral pleura. that I am not going to explain in detail. Okay, so double fold of the visceral pleura is the fissure, and anatomically the right lung, as I told, it is divided into 3 lobes, and it is divided by the oblique fissure and the horizontal fissure. So you can see the oblique fissure and the horizontal fissure. So the horizontal fissure separates the superior lobe from the middle lobe, and the oblique fissure separates the middle lobe from the inferior lobe. Okay, so here the question was regarding the oblique fissure in the right lung. So in the right lung, the middle lobe and the inferior lobe are separated by the oblique fissure. But on the other hand, in the left lung, we can see there are only 2 lobes, that is the superior lobe and the inferior lobe. So here we have only one fissure, that is the oblique fissure. So in the left lung, the oblique fissure will separate the superior lobe from the inferior lobe. Okay, so don't be confused, because the question you should read carefully. If the question was regarding the left lung, then definitely the answer will be superior to the inferior. Okay, superior lobe to the inferior lobe. But our question was regarding the right lung, so the oblique fissure will be separating the middle lobe from the inferior lobe. Okay, so keep this picture in the mind. Very important question, and especially for the ESICs and all, you can expect more questions from the anatomy and the physiology, and like these questions can be asked. So with this informative, very important question, we are coming to the end of another important session of our ESIC AIIMS NORCET series, and these 15 questions which are taken from the different aspects and will definitely help you to prepare well for the upcoming examination. So I think the explanations what I have given for each questions also was helpful for you. So any doubts regarding these topics or any other doubts you have, that you are very free to ask through our comment section. So thank you for watching the video. So stay tuned with us, and we will be uploading the next set of videos very shortly. Till that time, thank you.